thank you. So I did my fellowship in functional neurosurgery, which seems like an oxymoron. How many functional neurosurgeons do you know, right? At the Cleveland Clinic Foundation, and it's specific. I do deep brain stimulation here in Boulder County and have a program, and I'm super excited to talk to you about what's new and what's coming, because I gotta tell you guys, sorry boys, but functional neurosurgery is where it's at and where it's going moving forward in the next 30 or 40 years. So I do have a couple of disclosures. I am a consultant for Medtronic for neuronavigation and an investigator for things other than DBS for Medtronic. I also sit on the CEC and the DSMB for a study that I'm going to talk about, which we recently published results on. So I'm going to talk about several of the new targets and what some of those are and what we're looking at as far as new technologies, which are super exciting. Currently, deep brain stimulation, or DBS, is FDA approved for essential tremor since 1997, Parkinson's disease since 2002, and I won't stand on my soapbox and tell you that it is the gold standard, better than best medical therapy alone, because you've heard that before, dystonia, under a humanitarian device exemption, and obsessive compulsive disorder. This is not experimental. We have over 100,000 people worldwide, probably more close to 150 worldwide now, or 150,000 leads in 80,000 patients worldwide with these. There are three different ways to do this. As you'll note, there's the frame-based technique. There are two different frameless devices that are shown in the smaller photographs. All of them are designed to take an electrical wire and place it into a very small target, approximately 6 millimeters by 4 millimeters deep in the brain. There is some controversy about awake versus asleep deep brain stimulation for our pre-approved targets, and there are two different ways to do the surgery. I'm going to tell you my bias is to do the surgery awake, particularly for movement disorder versus asleep. Why? I'm going to show you some data that shows that asleep is really effective. You can put a target where you want it. But essentially all that shows is that you can take a tip of a lead and put it exactly where you want it. It doesn't show you that that's where you want it to go in the patient's brain. And the only way you know where you are in somebody's brain is to do microelectrode recording. Have the patient awake, listen to those cells all the way down, single cells, and different areas in the brain sound very different. And the only way you know that you know exactly where you are is to listen to that. And then we do the really cool thing in deep brain stimulation, which is with the patient awake, we turn it on. And we watch their tremor go away. It's the coolest thing ever. This is when grown men sob on my table because they haven't seen their hand write a straight line in 30 years. It's really, really, really heartwarming. And so we can test it not only for accuracy, we know where we are, but we can also test it for side effects. So my bias is, and if it were my brain, I would have awake brain surgery. It's not painful, it's very easy, it's kind of exciting, interesting for the patients even, they're laughing and having fun, and at the end of the day, I think it gives a better result. But I'm going to show you that there is some data out there that shows that if you merge a 3T MRI to an intraoperative CT, he did 60 patients, 119 electrodes. He did all three targets in the brain that we use for movement disorder. This is Dr. Burchill at OHSU in Oregon. And he was accurate, although GPI, which is a large target in the brain, was a little bit more accurate. He only had to reposition one for an error of greater than 3 millimeters. And here's where I'm going to, he said it's at least as accurate. Well, I don't play with at least as in the regions of the brain that are only 4 millimeters wide. So if we're 3 millimeters off, well, gosh, we're nowhere even near where we need to be. So again, my bias is awake brain surgery for awake DBS, but I wanted to show you the data because there's a lot of talk out there. Patients may ask you, well, gosh, why would I want to have surgery awake? Well, I'll tell you why, because you want to get it to the right spot. That's why. So, and it's very well tolerated. Currently, deep brain stimulation is an open loop system, meaning that there's a wire connected to an extension connected to a battery. And essentially that battery sends electricity in a certain configuration to the brain, but nothing comes back. It's open loop. So essentially all we can do is send electricity and hope that it's doing the right thing. Now I say all we can do because we know that it changes lives. Closed loop systems are what's coming next. That's where there's a sensor at the end of the electrode that then sends a signal back to the battery. And what we can do is then monitor what's going on in the brain at that particular time and place. And perhaps what we can do is change the stimulation. We can target and tailor the stimulation to what is going on in the brain at that particular time. And so if you look at this, it's correlated to beta waves, and we're looking at it in Parkinson's in particular. We know that the brain has certain types of brain waves, and so what we look at in Parkinson's are these beta waves. And what we think is that if we could monitor the beta waves and only provide stimulation at the times in which those beta waves are abnormal, until they correct, and then turn off the stimulation, and wait till they become abnormal again, and then stimulate again, so that we can choose and target, we can get better stimulation, particularly for patients with Parkinson's. We can do more, we can affect more. And this is currently in study, and actually there are some folks, UCSF is currently looking at these open loop or closed loop systems. We're really excited as functional neurosurgeons to get these. So now let's talk about current frontiers. I'm not going over every one of them, but this is my proof that this is where neurosurgery is headed, right? Look at all of these frontiers, all these targets and all of these places that we're going in the brain. I'm not going over every one of them, but I'll show you that there's not just one place in the brain that we can stimulate. So what we found is stimulating certain places in the brain affects certain diseases, and stimulating different places in the brain affect others. So there are all kinds of disease states that we may be able to affect by stimulating different areas in the brain and changing the electrical activity, changing the electrical circuits in the brain. It's super exciting in that way to look at and these are just the places that we're currently looking at. There are targets that I'm sure we don't even know about. Now, I didn't talk to you about something called Octavo Genetics. So something even cooler and more sci-fi, I mean, we are talking Star Trek here, is something called Octavo Genetics, where we can, just as the doctor ahead of me spoke about, we can infect the brain, or a certain area of the brain, with a virus. That virus has two different genes. One is the gene, turning on the gene that we want, whatever biochemical compound we want to turn on in the brain. The other one responds to a certain wavelength of light. Then what we do is we expose that virus via an implanted diode to that specific wavelength of light, so that when we want to turn the virus on, we turn it on. And then it turns on the brain. And when we want to turn it off, we turn it off by turning off the light. It's really, really amazing what we're probably going to be able to do in the future, or at least in my lifetime. But let's look at what we can do now. These are some experimental targets. So this is all FDA off-label, and I'm going to tell you that right now. This is looking at NBIA, or neurodegeneration with brain iron accumulation. It's a rare disorder, so a lot of these are orphan disorders. 23 patients. They actually self-mutilate. They have cognitive difficulties. And if you look at this study, and they have dystonias. And if you look at their disability, these 23 patients with deep brain stimulation, they were able to improve disability, they were able to improve quality of life, they were able to improve the severity of their dystonia over the course of 24 months. So this is a pretty promising and a pretty rare disorder. And this is the data on their quality of life. It's a busy slide, but what I wanted to show you is the top line, which is really the severity, which improved, the disability, and the quality of life. Because at the end of the day, this is elective brain surgery. So we're looking at improving quality of life. We're not curing diseases. We are not taking out tumors. We're not fixing pain, but we are improving quality of life here. Meigs syndrome. So a lot of the neurologists in the room will be familiar with this. This is an idiopathic, or meaning we don't know why, cervical dystonia. Head curls up and down. It's very painful. They also get blepharospasms, so they blink all the time. And they get dystonias of their face and mouth. We get some mixed results when we burn a hole in the brain, which I personally think is a last resort, never a good idea. Try to move a hole 2 millimeters to the right. Good luck with that, right? Try to make it smaller. You can't do it. But mixed results in thalamus and GPI in burning a hole. So In 2010, they took 3 patients, so not a lot, but 3 patients. We do these small studies with these patients because this is, in fact, invasive brain surgery with risks. They had GPI, so the globus pallidus internus target, GPI, same target that we use for dystonia, genetic dystonias, that is FDA approved. And they looked at the Burke-von-Marsden scores, and they got improvement at 12-month follow-up. Cluster headache, we had a talk about headache. I'm just going to run through a bunch of the targets just so you can see what's exciting and what's new. So this is PET, and it shows that there's actually regional blood flow activation in the posterior hypothalamus. We think with cluster headache where people get nasal running, they get conjunctival injection, they get terrible headaches, become suicidal even, respond to oxygen, but they can be refractory. 50 cases, these were mostly done in Italy because the hypothalamus is a very, very, very dangerous and bloody place to stick a lead. Lots of bleeds can happen here, so it's a dangerous target, but 50 patients, or 50 cases of DBS to the posterior hypothalamus. And the interesting thing is, what it looked at is the PET results, so what's going on in the brain, and it shows that there's actually functional modulation. What we typically think is, oh, you turn on electricity and you turn off something. You shut something down or inhibit something in the brain, and that's why things work. That's the way we think about movement disorder. In this, we actually know that we're affecting blood flow. We know that we're affecting blood flow in the posterior hypothalamus, which we think is the area that's creating these cluster headaches. So it's not just that we're shutting things down, we're actually changing the way the brain works, which is exciting. This is Gilles de Tourette. This is one that we actually do quite a lot, even though it's not FDA approved. It's probably going to get a humanitarian device exemption soon. There are several targets. Central median and ventral oralis nucleus of the thalami give us moderate results. Nucleus accumbens, which I'm going to talk about next because it's an exciting target. It's a reward center in the brain. That's giving us good results. GPI is giving us good results. But looking at it controlled, this is the best study we have, controlled, double-blind, randomized. It's crossover. So they put leads in the bilateral thalamus and leads in the GPI. They wanted to know which one works better. If we're already putting leads in, let's just put a couple in, let's see what happens. And what we think is that GPI is the better target here. But we are able to control tics in young children, in young people, in adults, but typically these are young children and young people who have tics that can be socially isolating, can keep them out of school, can prevent them from living a positive life. So Tourette syndrome is actually a very promising target for us. Aggressive behavior. This one's interesting. Franzini, remember I told you about those crazy Italians, they'll put leads anywhere. Dr. Franzini, he literally is, he's got this wild hair, he's got a website that talks about all of his studies, but then also has the best recipe for spaghetti sauce I've ever seen. I'm not kidding, same website. Check it out. Anyhow, he published in Neurosurgical Focus 6 patients. They went to the posterior medial hypothalamus. Remember, I said they're sticking leads in that hypothalamus again. They took aggressive patients, patients with self-mutilating behavior, and they had 5 of the 6 that exhibited significant improvement. You go back even further, and they have complete resolution in a case study in a 22-year-old with self-mutilating behavior, bilateral hypothalamus. So if you have somebody who they're chewing their fingers off, they're hurting themselves, they have this horrible life, what are you going to do? You're going to stop them. Now, I'm a bioethicist, we told you about that, so you guys aren't going to get away without a little bit of bioethics in here, I know. And so my ARS questions are embedded, and so the next question is it ethical to subject patients without capacity to surgical risk in an experimental fashion? You thought it was going to be an easy question. What do we got? No. Okay, so you're going to get really upset with me because I'm not going to give you a right answer. I do think that there are some issues, and I do think that there are situations in which we can take folks who don't have capacity to consent for themselves and ethically experiment on them. We have to have special considerations. We have to have special protections for these vulnerable subjects. But for instance, if you look at, and I didn't put in targets for eating disorders, but if you look at folks with eating disorders, one of the questions is, can they consent to experimental procedures? First of all, they don't even think they have a problem. Secondarily, they have to cooperate. Thirdly, their disease is killing them, so is it worth the risk? I think the answer can be yes, as long as the patient is willing to participate. Now, if you take somebody who has self-mutilating behavior, they actually can't even tell you that they're willing to participate, right? So then we have to look at what might or might not be the risks to them, what do their caregivers, what are the family values. So I wish I could give you a right answer. We don't have a right answer in bioethics. These questions are to make you think. Think about what it is that we do that we should be doing and what it is that we do that we shouldn't be doing, because my mantra has always been, just because I can doesn't mean I should, right? So, let's talk about obesity and addiction. So there are several animal models of obesity and alcohol addiction. We can take rats and we can make them, we can take away their satiety center and they will eat themselves to death, or they will drink themselves to death. So we can create these animal models. And I told you that nucleus accumbens target. That target is an amazing target because it controls, as I'm going to show you in a minute, it's a complex target with a lot of different circuits. So circuits in the brain. One area of the brain projects to another area of the brain, projects to another area of the brain. So we can hit those targets. And nucleus accumbens in an addicted patient looks like this. So what you have normally is you have this nucleus accumbens and it sends messages to this orbital frontal cortex. Well, your frontal cortex is your executive functioning. Your ability to, or we think it's where most of our executive functioning lies, your ability to make higher level decisions, to control your behavior. It also projects to the dorsal striatum, so that's where you act, that's actually motor, typically. And then it projects to the amygdala and hippocampus. Now why is this interesting? This is what makes that circuit. So it projects one way, and you can inhibit urges. It projects another direction, and it can create what, I hate the term reptilian brain, but that limbic circuit is really those deeper, baser desires in our memories. So those memories that are repressed that say, oh, I got that hit of alcohol and it felt good, or whatever that might be. So in the addicted brain, what you have is you have a decrease in the orbital frontal cortex, a decrease in the ability to make executive functioning. You have an upregulation in amygdala and hippocampus, that reptilian overarching desire. So if we put a lead into the nucleus accumbens and we change the way it works, we can actually re-upregulate the orbitofrontal cortex, re-downregulate through a positive feedback loop that amygdala, and we can affect addiction and obesity in that way. And so that's where the nucleus accumbens sits in the brain. There are several studies that show that obesity can be affected. More importantly, there are studies that show in alcohol and particularly heroin addiction that we can suppress. There are about 5 or 6 patients out of Sweden and Norway that they've looked at with heroin addiction. And these folks have been implanted voluntarily, so these are not subjects who couldn't consent for themselves, but voluntarily, with nucleus accumbens leads, and we have been able to suppress relapse with heroin, which is one of the hardest drugs to suppress relapse. They had one of those patients who relapsed. They changed the stimulation, gave them a little methadone, brought them down off of the methadone, and they were actually able to suppress relapse and take people off of heroin, which is just a horrific disease. Obsessive compulsive disorder. Now this has got approval. Has a humanitarian device exemption, and we have actually now had 3 patients in the state of Colorado who have been implanted for obsessive compulsive disorder. Its current target is an area called VCVS in the thalamus. And Greenberg out of Brown, the uncle or the nephew of the Greenberg, who's a psychiatrist, is looking at VCVC. Sustained improvement in their YBOX, Yale-Brown Obsessive Compulsive Disorder Scales, and it's currently in a multi-center randomized trial. And so these patients actually can go from completely non-functional to able to get back out into the world. They lose their obsessions, they lose their compulsions, and so they are actually able, the two folks that I have personally seen, they had all of these hand-washing behaviors, they could never go outside, they could never be separated, sets of twins, etc. They can now go and find separate jobs, they can actually sleep in separate rooms, they actually can be out in the world without having to watch or worry about germs. It completely changes their lives. So, as I was talking about, there are some additional protective measures we deem critical. So here comes another question. Do psychiatric patients possess capacity to participate in informed consent? Yes. And I would say that in these cases with some vulnerable protections of subjects, yes, they do possess capacity to, and I think that is the right answer in this situation. This is the target. It's VCVS, so we look at caudate, putamen, and GP. So GP, remember I said GPI? Well, there's a GPI internus, GPE externus, so we're not far away. These targets are not far away from one another. They're easy to get to in the brain. And this is data on OCD. It just essentially shows that there are multiple sites, multiple trials, and it's effective. Let's talk about depression. Depression was a big one. For my Medtronic folks in the room, I will just outright say there have been 2 depression trials that have failed. Okay, they have multi-center trials that have failed. I will tell you that that's because they were poorly designed. I'll also tell you that we think we know what the answer might be, but let's look at some of the data. There are 2 targets, that VCVS that I just showed you before, and the other one is subcallosal cingulate gyrus. These are the 2 different targets. There were 2 different studies, and there were responders. So there was a significant decrease in depression, an increase in function in patients with this SCG, subcallosal cingulate gyrus target. No patient achieving remission had a spontaneous relapse. And efficacy was similar. There were no hypomanic or manic episodes, so we're a little worried about sending them over the edge, the opposite direction. And a sham stimulation effect was found, likely due to a decrease in their depression after a surgical intervention. They have a little hope. They become a little less depressed, but it was mild. Here's the target, and that's where the lead would be placed bilaterally in the subcallosal cingulate. Data shows Lozano, so Dr. Lozano out of Toronto, he's one of the gods of neurosurgery. 21 patients, bilateral electrodes, significant decreases in Hamilton Depression Rating Scale from baseline. Reduction in the symptomatology was associated with amelioration of disease severity in responders. That's the change from baseline over time in responders. So those people who did responded well. And the percent of subjects meeting criteria for response. So as you can see, there actually were a fair number of people meeting the criteria for response. Interestingly enough, we were talking about PET. This shows the change in glucose metabolism and blood flow over time. And it's not just affecting that subcallosal cingulate gyrus. It's not just affecting the area where they targeted. It's actually affecting several areas in the brain, letting us know that that circuit I was talking about, that electrical stimulation actually changing that circuit. Then if you go to a 3 to 6 year follow-up, 20 patients who received DBS at SCG, average response rate was pretty good, right? Last follow-up, they still had a 64% average response rate. Functional impairment in the areas of physical health, social functioning progressed to last follow-up, and no significant adverse events were reported during the follow-up, meaning no hypomania, no suicides, none of those types of things. The problem is that it didn't meet the standard for the larger center trials. Now, one of those reasons is those are 2 different targets, and at our last national meeting, the 2 PIs for those 2 targets said, hey, guess what? Here's the type of patient who responded to my depression study. And one of them, with one target, said, gosh, my responder was the person who was almost Parkinsonian, who just withdrew and wouldn't move and wouldn't talk and wouldn't do anything at all. The other one said, oh, well, that's interesting, because my responder was the one who was sort of histrionic and throwing a fit and screaming and crying and throwing themselves on the ground. What that tells me is I think that we have to have the right target for the right type of depression. Furthermore, I have personally seen responders. I've seen it change their life. So I think we just need to design a trial for depression. And if we can design a trial for depression that's positive, we can change the world. We can change our country in a big way. Let's talk about Alzheimer's. This one's really close to my own heart because some colleagues of mine and I just published on the advanced trial. So there's a lot of studies that show that there can be some effect with Alzheimer's, with increased connectivity. And this is that circuit, just showing that circuit again. And our target is fornix, bilateral, where is it, hippocampus, entorhinal to fornix. And I'm just going to skip because we're running out of time. So those are our leads right there, 40 patients. This was a safety trial. Now, interestingly to the neurosurgeons, this is early stage Alzheimer's, bilateral, transventricular placement to the fornix, and it's safe in these patients. See, Dr. Rajpal over there is like cringing, bilateral transventricular. Oh, patients bleed. Oh, they get worse. They don't. They actually don't get worse. And so that is published. It came out in August in 2015. We're going to go to a major multi-center randomized large pivotal trial in the next 2 to 3 years and see if we can affect Alzheimer's. Different place in the brain, entorhinal. This was for epilepsy. This was out of the Santi trial. But what they did find is when they put those leads in and they were looking for other things they could stimulate, and they could have a patient learn better, learn faster, learn quicker in a task where they're driving and navigating on a video game, on a taxi game. So we know that we can actually improve cognition in cognitively normal patients. So here comes, what about enhancement of non-demented subjects? Let's say Alzheimer's works. What about taking a regular person who just wants to be a little bit better? What do you think? Is that ethical? We're kind of split, right? So the argument really is, it's your brain, you know the risks, and the risks are low. Why not? The other argument is the next question. The other argument is, the rich person, they can afford it. So do their kids, or do they get the advantage over the poor person? No. Doesn't that change things? I mean, I'm just telling you what the ethical arguments in. I'm going a couple weeks from now to the American Society for Bioethics and Health. That's all they're going to talk about is this kind of stuff. It's interesting to see what you think. The next question is, does the consenting adult have the right to surgical enhancement of their brain? Not should they, do they have the right? That's an important question, right? What do we say? Yes. Interesting. I think there's more controversy in the bioethical circles about this than there seems to be in this room. But we like controversy. Philosophers like controversy, right? So what I want to say about this is these questions were essentially to make you think. They were make you think about what's right, what we should be doing, what are we coming up on. I know this talk has been sort of all over, but that's because what's coming in deep brain stimulation is all over the map. It's super exciting. And so I'm going to say that the future's so bright, I got to wear shades.